Welcome to the Talking HealthTech podcast. My name is Peter Birch. Today on the show, I'm joined by Phil Offer from BestMed. G'day, Phil. How you going?
Hey Pete, it's good to be here. How are you going?
Really good. It's been a bit since we've done a bit of a showcase of BestMed on the podcast. People can go back into the show notes and check out some prior content. And of course, you're listing on our website to learn a bit more. But I felt like it was a good time to connect because we've had a few conversations out and about at those industry events that we all attend, and felt it was a good time to check in on the pod because I feel like there's a bit happening on the BestMed side that everyone in the ecosystem could get some value on learning about, particularly around that the challenges in syncing data and information between primary care and aged care around medication specifically. But firstly, for those unfamiliar with you, tell us a little bit more about you and your background. We'll go from there.
Yes, certainly. Thanks, Pete. I've been in digital health now for just over 12 years, and I stepped into that sector after over 16 years in the telco industry, starting in the UK and then coming down to Australia. And that period was like doing an MBA every 3-4 years as we went through the various generations of sort of telco. And actually, personally as well, I also switched disciplines. I went from finance. I'm a chartered accountant by training, then went into marketing and had digital and sales. So it was a great sort of test bed for that. And it was at the end of that journey, I once got to go to the West Coast of States, go and see Google, Apple, Microsoft, and this will date this also BlackBerry on a bit of industrial tourism. And actually, that's what opened my eyes as to what software could do. So when I was looking around as to where I might go sort of next, rather than take the next move internally, I looked to go into software. And I guess like many people, partly by luck or sort of accident, was in the health sector, and the role of medical director opened up. So I worked into there for 3 years to turn around and sell in primary care, then moved into working for social enterprise at the George Institute, and then landed in emergency telehealth about 4 months before COVID arrived. So again, I saw and drove those waves of COVID and saw how telehealth came from being not clinically proven to be the thing that people really wanted to use, before I then got the opportunity to come here and lead with BestMed, that really works in that nexus of medication management between aged care, GP, and pharmacy.
Got it. You know what? I forgot that you were your time at medical director and the primary care side. So yeah,
Mm.
that the breadth, and forgot that you were a chartered accountant. So all these little things that you remember. And it's interesting actually. I'm sure like some of that, particularly in the primary care side, it'll come out in our discussion, because when you think initially BestMed, you mentioned, medication management and the aged care and primary care. It's like, okay, that's a bit niche and specific, but I think as you start to unpack it just a little bit, you realize how much of a need there is. So maybe let's step back a little bit and look at BestMed, what it is and the problem it solves.
Yeah, the problem it solved was actually really well shown by a study that Uni of Sydney did a number of years ago, actually, which called GraceMed, which it compared the records where they were then paper and very siloed between GP, pharmacy, and aged care. And for every 100 records, they found 72.6 discrepancies. So more differences than there were the same, actually, which makes sense because bits of paper were being faxed and phoned around, and there's no one common sort of piece of truth. So why would you ever expect them to be the same, really? But then when you drill into that and look at where the errors were or the differences of what could happen, of those discrepancies, about 40, I think 9% odd could cause moderate harm, and around 9% could cause serious harm. And there are many cases of when that did, which obviously the Royal Commission showed as well. So BestMed started out actually as a pharmacy that was supporting aged care and built this software platform that connects all three of those parties to one live cloud-based medication record. So there's no going around and going, what is the latest medications? You always know what's been prescribed. It's the same thing that the pharmacy is packing and the home is administering from. And so that journey, which we're celebrating 10 years, as we've built out that software and also now actually connected the families so that they can see up to date the latest medications their loved one is on.
Interesting. And so BestMed, the platform, cloud-based solution, it sounds like it's accessed by all the different stakeholders. So the primary care side, the aged care facilities, and you mentioned patients slash carers or families as well. Is that right?
Yes. Yep. That came in sort of last year. So, I mean, we've sat to many of those conferences and talked about interoperability and standards. this is an area where it is in action. So, and it's two-way workflows that are going around to make things more efficient. And that's actually helped to sort of build the product.
Got it. If I think about, I mean, that's the statistic you provided before around, near pretty much 3/4 um, of those medication orders or whatever had errors, and a good half of them have potential to have moderate harm, 10% significant from memory. So, like, I get the, if we can improve that by digitizing it, then that's a good thing. And I guess that could potentially improve things from the clinician side in terms of reassurance around adherence or whatever, but obviously for a patient and family. From
Mm.
the aged care facility side, or from the provider's perspective, I'm not too familiar in my day to day in terms of the biggest problems that they need to solve, or I guess the workflow. Like, one thing we don't want to do is burden a facility or whatever with additional stuff to do, and just because it's nice to have it in a digital format instead of on paper. What is the benefit to, say, the aged care providers side when they look at, using medication management software?
I think fundamentally, it keeps that resident sort of safe, and we've seen clinical reductions. When we rolled out one of our largest home groups in there, Regis, they've shown this at conferences, they saw 63% reduction in medication incidents. So by investing in that software, you get to see, first of all, you get to see everything that's happening. You see the data of what's occurring. That allows you to actually take those incidents down. But also to be sustainable, you're right, it's great if you've got that there, but you've got a lot of work to do. And this sector has had a huge amount of regulatory exposure, which I think outside the industry, very few people in healthcare probably understand. If you've seen the same level going to other sectors, I think we would have heard it far more visibly on sort of some of the podcasts. So they've got a lot of focus in there. This, as we've looked at, this software goes in, saves about 114 sort of minutes per day in there, because the efficiencies you get from the way you're administering, making sure you've got the right supply of drugs that are in there, and the ability to be able to reorder. And that sustainability is obviously really key in this sector, not only for our own business model, but obviously for actually the aged care providers to be able to bring it on and invest in it. And more importantly, that there's also the emotional sort of benefit. We see it in the surveys when we go in, that people feel, we get sort of surveys in the ratings in the 90s, that they feel supported by the software. And it was one of the GMs of the homes that said to me that when I walked into a home that had BestMed after the implementation, I could sense and hear from the staff the fact that they felt more supported. And it was actually taking the stress out slightly. There's still going to be lots of instances that happen in aged care home, but this was one less thing they had to worry about, because they knew that the system had their back. You knew what those medications were on. It's helping you. It's giving you warnings, and it's got clinical decision support, and you're connected up to the rest of that clinical team to be able to help manage those medications sort of in there. And I think that emotive level, that's part of why we see the response from the users, and obviously the acquisition that we've been able to get to, because of the benefit that we bring to them actually in their day-to-day work.
Yeah, I think about it's interesting you said the emotive element. Like, I think about the in a high pressure environment, or when you're under various constraints, be it from a aged care facility perspective, you, at the current lens as well, is like, you don't want to be doing things wrong, and not just because you're caring for the individuals in the facility, but with the attention that's been placed on the industry, I imagine there's a lot of conscious of just improving things bit by bit. And I guess in the medication management side, it's kind of high stakes, because it's a necessary component for a large demographic to have medications. But then, if you're responsible for distributing amongst many individuals, if you get it kind of wrong, that can be a really big deal. And if you mix things up. So yeah, the more I think about it, it's a pretty critical area that I'm surprised kind of hasn't been addressed until now. But I guess you've been in the game for a bit. It's been around 10 years for BestMed. Is that right? So you've kind of been on that journey over the process.
Yes, yeah, BestMed, it's 10 years just last month, and I've been on this journey now for sort of 3 years. So, and we started out actually at one of those pharmacies that was supporting around about 50 aged care homes. And like a lot of software, there's got to be a better way of sort of doing this than the manual process that was occurring and people putting sort of medications into sort of packs. So as the founders looked out, they looked around the world to see where this was done well, and they looked at some of those countries that were further along the demographic curve, sort of Korea and Japan. And they looked at how you could pack that medication to actually into sort of sachets that was more efficient. And also there was technology out there that could actually use the latest image recognition technology to check that the right pills were in the sachet. So you could take those error rates down to almost sort of 1 in a million. So we're able to distribute some of that hardware, and they started to be able to do that. But of course, you need data to load into those devices. And so that started on the software sort of journey. And our CIO was part of the family and could build that sort of code base out. And the principle was always, how can you stop people, copying over or retranscribing data? Because it adds no value. It just adds risk and errors in there. And so that started the path of, first of all, how can you get the pharmacy operating well to take those packing errors down? And then how do you bring it out to the aged care home? So you're not having to copy over that medication chart where there could be an error. And then finally, it went to the doctor. So you're going straight from the doctor prescribes, and nobody is changing that data until it actually goes into packs those pills into the sachet. And that's what actually allows you to take that error rate down. And then you can obviously build lots of workflows around that. So we jettisoned, obviously, our own pharmacy many years ago to take away that conflict of interest. But there's over 1,400 pharmacies that use the software now. And in aged care homes, over 1,250 are actively using it and more sort of coming on board. So almost 1 in 2 homes are using the software in Australia.
Yeah, wow, that's good reach on the aged care provider side. And that's impressive. What I think's impressive too is that typically when I think about connectivity in, say, primary care, it almost like we're really trying to be better connected, but it's always within primary care. And then we try and be better connected in aged care, but it's always in aged care. And then in between things, we rely on patients or carers being the integrator with a big plastic tub in the boot to take a bunch of files and medication and here's the bridge between say primary care and aged, and then you got pharmacies, like all the different perspectives too. How do you go about those kind of previously somewhat impenetrable ways to interop across I guess multi-modalities within healthcare?
Yes, I think what has probably helped us is because the average resident that we've got is on 11 medications a day, and some of them a lot more, and they're getting it multiple times a day. So you're right. So the risk within those types of medications is really great. So it helps focus everyone on that journey as to, okay, what is the safest way of sort of doing it? And you're right. We talk about interoperability of law. For BestMed to work, you have to be able to deliver that. And so I think it's because of those clinical benefits that helps the pharmacy get on board, as well as they could pack faster and safer, and actually at a lower cost than if you were manually doing it. So they were happy to get on board. The homes, as we've talked about before, benefit for clinical and safety. And then actually the doctors, when you showed the empirical data, so they were also coming on board as well, which having been in the primary care sector and known, most people want to stay obviously within their GP practice screen. But actually, we saw doctors coming on board there as well. Another factor I would say is that from the Department of Health and Digital Health Agency, setting the standards has been really important. So actually the charts which BestMed had, we participated in the trials actually for the medication chart standard, which we're now getting to conformance to. So I think having that standard sort of set, and government working very constructively with industry has also been a key part of that, and they did help the aged care homes to get this software and to be able to nudge them into it. That's been a sort of key part. But ultimately, as we know, you can design the standards, you can put the infrastructure out there. It's the workflows that make the difference. And I think with sort of prescribing, a bit like with e-scripts and med charts, it's obviously been a bit of a sort of silent voice of success of showing what can happen when interoperability works, and actually you get that process sort of right. And when you do, people get on board because the workflows work, and and the quid pro quo is there. So is why they'll come on board. Actually, you're not asking them to say, "Look, do this extra bit of work, and it'll be safer," because it sounds good, but as we know in digital health, you don't always get across that sort of barrier. So you've got to be able to line up sustainability of that process with the clinical sort of benefit. And that's something which always focused on for all of the stakeholders in our group.
It's interesting you bring it up because I think about that too. Because often in a environment like that you're talking about with different stakeholders, I guess firstly, if it was outside of healthcare, and data was less of a sensitive nature, and a bunch of other reasons, it's not as simple as let's build a tool and then connect up some APIs and then allow it to kind of just go between each other and give everyone a login and away you go. So that's why you need the standards and you need the build it into the workflow, which usually means appearing on the front end of tools, and it all kind of just magically works eventually when it's all built, so that there's not that friction. But from experience, there's usually in those environments where everyone contributes, sometimes there's one group, let's say the aged care facilities, that really benefit, but then there's others you need that to contribute, but it's kind of like, we need you to contribute. I'm not sure really the value that it provides to you, but if you do, that'd be great. And like you say, because it's safer. If I think about it from the outside, like how, like for the general practitioners, for GPs, like where have you seen the benefit for them to, because it's super important for GPs to contribute to this whole kind of picture, but sometimes it might be hard to see the value. And the same token, GPs have a lot of things to do as well. What's like, if I took that lens from the GP side, what does this look like for them?
Yes, and I would say that's where our most recent announcement actually to integrate with best practice has been actually to make that even sort of easier for GPs. Because yeah, when the home says, okay, we want to use this software and talk to the doctors, yeah, there's a range of opinions that doctors always have because they really want to be able to control those workflows as they do within their practice of the system. The difference is, of course, is that those doctors are usually physically visiting the aged care area. So they're already often in the IT environment, having to deal with the clinical system that the aged care home does, and then sort of traversing what they've got in their own practice sort of software. So I think that's one of the things that help that sometimes the doctor is actually not in practice, is out in the aged care area. And then once they got over that barrier, if it's a different piece of software, yeah, it was the benefits it was bringing back to them as well, actually. So they actually could sort of the observations they were getting back around the resident, how effective that medication was being, it's actually making their job easier and safer when they're in the home. And I think that one of the sort of examples of that probably is when we advertised for clinical advisory panel, we were just blown away by the number of clinicians that actually wanted to participate and said to us, because it actually benefited me in my job and made it easier and safer. And I really want to be in your advisory panel. So there's over 150 people sort of applied sort of for that effectively. But we're very excited around the best practice integration that will take out that last sort of mile of having to copy and paste or various other ways of sending that data back to the practice management system, and that will now be in sync into BestMed as well, actually. So, but it's often, I think the difference part of interoperability was, the doctor is often coming to the aged care home, so they can actually see the benefits for the home and how it could help them.
Yeah, that makes sense. I guess if I think about some, over the years for BestMed and iterating and like further refining it so there's less of that friction and more of that engagement, I imagine there's kind of some guiding principles that your team has towards product design, because the feeling I'm getting is that you guys get deep in the weeds in terms of looking at how do we optimize for this part of the process, which ultimately then means more people can use it. Walk me through some of those guiding principles you use around product design.
Yeah, so certainly one of the guiding principles is, we never want to retranscribe the data. So whoever's a subject matter expert adding it in, that data has gone in. Nobody else ever wants to be able to sort of copy that back. So once you've got that, that helps drive a lot of where you go within the platform. And that's why most recently as well, we've integrated with all but two now of the clinical care systems in the aged care home, because often they want that progress note copied over. They want to know that a PRN medication was given. And so we've actually been able to integrate into there as well, actually. So anytime there is, double click or put in copy and paste, take that piece sort of out. And then it's that two-way flow of information, as you said before, actually, is, well, what's the other benefit the person in there? Which is why our clinical advisory board has got all of those three groups in there represented, actually, because it's easy to build it for one area and say, you do the work for me. But we know that that's not going to happen. So we make sure that we're having those debates. Obviously, we look at it as a product design. We have an independent clinical group obviously looks at the safety, but we can also tease out okay, this really helps the home sometimes. How do we make it easier for you? And some of that is because for the reports that the Aged Care Commission, the Quality Safety Commission, when they sort of visit, it makes it easier if the doctors have actually put some of that information in, not in free text form. So getting that balance right between saying to the doctor, we really need this information in, so that actually helps the home with their compliance. Those are the things that we often try and sort of balance well, as to how can we do that so it can make the doctor's job sort of clinically safe and sort of easy, and not too much sort of work going in there. So you're right, it's a very delicate balance and quite nuanced sort of workflows to make sure that it's safe, but it's also going to be used and is sustainable. And that's where we sort of reach out to talking to the homes and all the stakeholders to go, have we got the balance sort of right? And where we haven't, we'll sort of fix as well, because we spend sort of millions of dollars just looking at medication management, which is one of our advantages, I think. So we're not distracted by having to do the other groups that you do when you're in a sort of PMS or a big clinical piece of software. It allows you to get that focus sort of in there, and to be able to iterate rapidly if you've got some additional feedback that says, oh, that didn't work out as you planned.
I mean, a couple of things in that. Just 100% agree with you on solutions that just hyperfixate on specific problems to solve that have material benefit when solved properly, because be it in hospital and EMR side or primary care with the practice management systems, they all have a capability to some degree, but all of them now also openly want to partner and collaborate with people that vendors that can solve the problem more comprehensively, like in this example too. And there's I just wanted to reiterate on your point too around bringing that advisory board together is super important when you can give visibility beyond your part of the process, particularly when different parts of the ecosystem need to work together. Sometimes you may not have a visibility that this particular thing I'm doing is pushing a problem down the process, or this thing that I'm doing is not even adding value when I thought it was actually adding value, because you don't even use it. So there's some valuable advice for those creating solutions in that one there. Look, it sounds like...
I mean, I've also, the other advice is, when you get it through is, ring up the doctor. I always do that when I get that advice coming in. I used to, when I was in the GP land as well, actually, because hearing it, you get obviously the written version, but actually just hearing it from their voice and the emotion that might be in it and the way they sort of articulate it is really sort of important. And also just helps differentiate as well, actually, because it's amazing. People will go, oh, they never ring back, or they're cool. I will actually, if the doctor ever rings to me, I do ring them back and sort of hear that. Doesn't mean I get the odd text message every now and then as well, but it's really important, because it's part of the way I would go to conferences as well, actually, because actually you can look at the data, but actually just hearing the anecdotes or bits that you might have sort of missed, it's really important, actually. And I encourage the same thing with the team. If we're not out there and listening, then we're going to miss things that we should be working on.
No, that's so true. It'll keep you busy though, and it sounds like you've had a busy couple of years at BestMed. Given that it's a 10-year celebration time, surely you're making a little bit of time to celebrate some wins. What are you doing?
We have taken a moment just to be able to sort of mark that milestone. And with our customers, we've actually launched something called Connect to Celebrate, which works with a social enterprise called Connect the 40. Because one of the most scariest stats in residential aged care is that 40% of the residents don't have any sort of regular visit. So they're just there. And you imagine the burden that puts on the care staff, sometimes trying to help fill the gap, and that emotional support that's not there, actually. So Connect 40 helps to generate some unique experiences to be able to enliven life for that resident, and something that they'll remember. So 3 homes will have the chance to be able to do that. So we launched that competition a week ago. Already 20% of our homes have actually nominated their sites to be able to do, which is amazing. And it's part of the great thing about this job is the response you get back from the homes. So we'll be picking that winner. Nominations close on the 5th of September. So we'll be doing that there. And internally as well, we've had a chance to say thank you to the team who incredibly dedicated. We are a 24/7 operation. So our clients work that way, so do we. And to say thank you and the support that will go back, actually. So as I said before, we did actually go out and just record a bit of a team anthem, that has been playing now. It occasionally hits onto my my music sort of playlist. But an opportunity just to say thank you and acknowledge that. And then we're on and building for the next 10 years.
We'll have to work out some creative ways to work in maybe that song into the end of this episode. Who knows? If not, we'll have to link it up for people to check out afterwards. I love that initiative, though, of giving homes the opportunity to acknowledge that I wasn't aware of the 40% don't have those regular visitors within facilities. So great initiative, great way to mark the milestone that you have. I'm conscious that we've recorded this interview for 20 something minutes, and I don't think either of us have mentioned artificial intelligence. And in 2025, when we're doing a podcast episode about innovation, I feel like that's a missed opportunity. So looking ahead, is there things that BestMed are doing around that AI space?
Yeah, I mean, for us, we look at it as intelligence, first of all, actually. So the platform, and part of what it does now is how can you've got obviously the data, how can you bring that forward so you can get actionable insights? So there's already intelligence in that piece. And we're looking at how we can bring that more to people to be able to alert them, to actually try and avert some of the issues that might be sort of coming around there at this stage. So there's a lot of testing and trialing within that. I'm using some of the tools already of both the ability to do the code, ability to check, and also just how we surface some things and then make sure we get the favorites in there. In the pharmacy side, we already actually use some sort of AI image recognition technology. As I said, it actually checks the shape of the pills and the right pills are in those sachets. So when somebody rings up, we're able to show, okay, well, this is the sachet that was packed, and this is how we know it's actually sort of safe for you. And that's been in operation for a while. And we also do a broad partnership with Macquarie University's Australian Institute for Health Innovation. We've had 3 projects on there, and the 4th one is they've recently been awarded $4.1 million by the Medical Research Future Fund to look at how AI can be used in de-prescribing. So that project is underway, and we take the benefits, as we have done with our Family Connect product, some other decision support tools. We can ingest those into BestMed sort of in the future. So it's incredibly exciting as to what technology can do. We're always focused on finding just the right tool to be able to use it. Sometimes it will be a large language model in the way we do support AI. Sometimes it will just be how we program. But the most important thing is the outcome for the homes. So, and we can see, there's still lots of potential we can do to be able to improve. So we'll take the right sort of tools for that. And we've already got some AI in our solution, and you'll see a lot more sort of coming when it's the right tool to be used.
Yeah. No, 100%. That approach of, let's be aware of the technology available for us to innovate on, but be laser focused on, how we can, even make those 1% improvements every day for end users and the end patients or residents, then that's what it's really all about. So being aware of what's available, that's how we do it. But look, Phil, it's been great to sit down and have a conversation here on the podcast. All the details will be on our website for people to learn more about BestMed. Really appreciate your time. Thank you so much.
No problem. Thanks for having us, Pete.
We hope you enjoyed this episode of Talking HealthTech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.